My name's Fleur McQueen-Smith. I'm the interim vice president of the Saskatchewan Public Health Association. So I'd like to welcome everybody here today on behalf of SPHA. Running WebEx for us is Wanda Martin, who is the interim president of Saskatchewan Public Health Association. So I'm just going to introduce our moderator and our panel for today and then hand it off to them. So moderating for today, we have Dr. Michael Schwant. He's an assistant professor in community health and epidemiology here at U of S and deputy medical health officer, population and public health in Saskatoon Health Region. Dr. Schwant's a public health physician and researcher with a strong interest in health equity. After completing his medical doctorate at the University of Manitoba, he carried out residency training in family medicine at Women's College Hospital in Toronto, as well as specialist training in public health and preventive medicine. Dr. Schwant is currently studying social determinants of health among migrant workers and impacts of air pollutants on health services utilization. Within Saskatoon Health Region, he provides physician leadership to environmental public health programs, as well as working with community-based organizations, non-governmental organizations, and government partners to study and promote healthy environments. And so for our panelists today, we have Dr. Carrie Bourassa and Dr. David Jones. Dr. Bourassa is a professor of Indigenous Health Studies at First Nations University of Canada. She's Métis, and she was born and raised in Regina and received her academic training at University of Regina, including a PhD in social studies. She has worked in policy development with the provincial government as well as in academia. Dr. Bourassa is passionate about teaching and research. Her research interests include the impacts of colonization on health of First Nations and Métis people, creating culturally competent care and health service delivery, Aboriginal end-of-life care, and Aboriginal women's health. In November 2014, she was inaugurated into the College of New Scholars, Artists, and Scientists of the Royal Society of Canada, and she served on CAHR's Ethics Committee. Dr. Bourassa was recently awarded funding from the Canada Foundation for Innovation to develop a cultural safety evaluation, training, and research lab. In this lab, she's going to examine how to create cultural safety and healthcare service delivery for Indigenous people. She sees this work as a way to implement many of the recommendations from the Truth and Reconciliation Commission, as so many of them had to do with healthcare. And Dr. David Jones has a medical degree and a Master's of Health Science in Community Health and Epidemiology, both from the University of Toronto. He's worked in many areas of clinical medicine and public health in his long and distinguished career. He's no stranger to Saskatchewan, and he served as Chief Medical Health Officer and Executive Director of the Population Health and Primary Health Services branch for the province here from 1995 to 2002. In 2004, when Public Health Agency of Canada was established, he was appointed as its first Chief Public Health Officer, a position he held until 2014. In this role, he helped steer the country's response through things such as the H1N1 pandemic. So many of you are probably very familiar with Dr. Jones's work. A clinician and researcher in a broad range of public health issues, he's taught at the undergrad and grad level and has currently a faculty position with the University of Manitoba. He's also been very active in many associations, including President of Canadian Public Health Association, Vice President of American Public Health, and Vice President of the American Public Health Association. In 2010, he was awarded CPHA's highest award, the DeVries Award, honoring his outstanding contributions in public health in Canada. After having strokes in 2012 and 2015, Dr. Jones is now working fewer hours, so I'm really thrilled that he actually came today because I wrote, oh yeah, he's working fewer hours, but we did get him. So he's doing teaching and advising on public health through Health Canada's First Nations and Inuit branch in Atlantic Canada and Ottawa. He also serves on the national board of the Heart and Stroke Foundation, and you actually might hear him on the news in the next few days here because he's doing some Saskatchewan media also while he's here on a recent report that Heart and Stroke Foundation has released on stroke and dementia. So with that, I'm going to just hand it off and just say how thrilled the SPHA is to have these two speakers here today for us, and I think we're going to have a great afternoon. Thanks.
Great. Thank you very much, Fleur. It's a real honor to have two true trailblazers in this field of public health and two really inspiring individuals with us today. And I'd also like to thank all of the researchers, practitioners, students, and community members who have joined us both here at the College of Medicine and also who are tuned in online right now. As just a matter of the format that the day will take, we'll start with some opening remarks from our panelists, and then get into a few questions. Many questions have been submitted by people interested in the field, and we've tried to gather some of those into themes so that we can start a conversation. As well as that, here in the room, you'll probably notice a silver button in front of you, and that's the pathway to asking a question of the panelists. So if you'd like to, at a time that's right, try to maybe raise a hand to visually indicate where you are, and then make sure that you press that button so that your questions and comments are captured for those online. As well as that, those who are online have the opportunity to ask questions through the interface you're using, and Wanda Martin here in the room will direct those to the panel as they come in. So without any further commentary, I'd like to turn it over to you. Thanks.
Okay. Merci Fleur, merci Michel. Bon après-midi tout le monde. C'est mon grand plaisir encore d'être ici. It's always good to be back in Saskatchewan, not simply because I have a daughter and two granddaughters living here in Saskatoon. So any excuse to come back is always a good thing. But I'm also a clinical professor here, as well as professor at U of M. So the prairies have become very embedded in my soul, I must say. It is. I must say I had an interesting journey here. On the plane coming here, my zipper broke. Fortunately, my daughter picked me up, and Mark's Work Warehouse is very close by, so I hope you like my new jeans. But it is, maybe it's a metaphor for it, because I usually have a spare pair of pants, but I decided this time I'd bring shorts instead. But it is really about, I often talk about public health as duct tape and binder twine. That public health is the organization that just gets it done. And if you go back to the 19th century, it really was the very early days of understanding that it wasn't simply acts of God, that in fact there are things that we can do to prevent some of these nasty things that happen to us, to actually prepare for them and to respond to them, and to reduce the risk. And that as society we have the means to do so in different ways, which we've come to call the social determinants of health. But Disraeli in the 19th century would say that the health of the public is the foundation upon which rests the happiness of the people and the welfare of the state. And I think that's equally true today, even if we sometimes forget that public health is actually that first order of public good that governments are responsible for when it comes to health. The definition I like to use is a slight modification of the one that you see in the Dictionary of Epi, but it is the organized efforts of society to improve health and well-being and reduce inequality. And that is something which means that public health isn't about just a set of programs and services. It's about a way of thinking about the problems. Sir Michael Marmot talks about getting at the causes of the causes, understanding not just those proximal causes, but the things that underlie it, whether it's social inequity, whether it's racism, whether it's cultural, whatever. All of these things, poverty. And poverty is really a constellation. And so I'm going to talk about it. I'm just going to sort of throw a few things out there, hopefully to spark a bit of question and debate. And there's two things that you'll see here at U of S. I was very pleased, especially given the nature of the university, the multi-faculties that you have there, that really did start to embrace the notion of One Health. For me, that sense of understanding about the interface between animal and human health, the environment and the economy, understanding those things is actually key. And the challenge is that many of our wicked problems actually sit at the margins, between disciplines, between perspectives. And in times of economic challenge, we tend to retreat to core mandates. And those wicked problems don't get addressed. And yet that's probably one of the most key times we have to do that. The other is the social determinants. Whatever you want to call them, the language has changed, whether it's population health, social determinants, but it is those factors, including health services, that actually make a fundamental difference to health. And it's at the end of the day, it's all connected. One of the things that, I'm a doc. I trained in medicine and family medicine and then preventive medicine, public health. I can't deny it. But it is about, there's a couple of concepts that I think are really important to reaffirm. In medicine, we always talk about first do no harm. We seem to forget that a lot as we move to interventions that actually may not be helpful, or ignore things that might be particularly on the preventive side. But that's a very important concept. The other is whether we're talking about medicine or therapies, or whether we're talking about a program or a policy, often talk about ensuring that it is the least intrusive, most effective, with the fewest side effects. And if we look at judging things on that basis, the chances of actually making things worse are much reduced. The chances of actually focusing our efforts on the balance of promotion, prevention, treatment, and care in a way that actually will benefit all populations, no matter where they live, no matter what their background, I think is really key. The other thing to remember is that today's problems often were part of yesterday's solutions. Medicare in the 60s solved a lot of problems in terms of access to care, people going bankrupt, etc. But then we sort of get stuck in the mold in terms of not being able to think outside of that. And so today, and while we've probably been talking about it for 30, 40 years now, but really thinking about what is that balance of programs and services, and what is that link to the rest of society, those things that actually have an ability to make a difference to social determinants. How do we actually influence those? Because at least for public health practitioners, it is actually more about what we influence than what we actually are able to manage or control ourselves. Once the basics in place, I've talked about social determinants for many decades now, and I was always struck by how much time we would spend conscientizing, and certainly as when I was in university in the 70s, sort of talking about, don't you understand that poverty and gender and employment, in fact, well, we've known that for a long time, but what do you do about it? Don't you understand? As if somehow conscientizing, revolution will come and everything will be better. Well, revolutions actually do make me a bit nervous in terms of unintended consequences. On the other hand, what we found over the last 10 or 15 years is much more of a focus on what can you do about it. In the terms of, us talked about environment in the 70s, think globally, act locally. So you have to be thinking about the big picture and all the connections and how things are connected, but then finding very practical ways to deal with it. And we can, if you want, talk a little bit more about that later. But once the basics are in place, once that, you have a roof over your head, you have enough income that you have food in your belly, you've got clothes, you've got the ability to participate in society, what I would observe is there's two things that fundamentally make a difference between okay health and really good health. And why it is that you can go to different communities. I worked in Port Newfoundland, and one of the things, and the same with rural Saskatchewan, two communities, similar geography, similar genetics, similar economy, one's functional and one isn't. Why is that? That, I think, is actually the big challenge for public health. Because poverty is a constellation. It's not simply about lack of income. It is lack of capacity. It is lack of connection. And the two things that I talk about, one is that sense that you have people you care about and care about you, that you are connected. And we see that in no matter what age, male or female, those who are not well connected have twice the risk of dying of those that are well connected. Secondly is a sense that the decisions you make and the work that you do makes a difference to your own future. You actually have some sense of control. And yet we have now, for a long time, these policies, whether it is the reserve system or residential schools or the welfare system, that take away people's ability to own their own futures. And we make that as a deliberate policy choice, almost as if to say, we really want people to be stuck where they are and to not create the opportunities. Because if you really want to make a difference, you have to allow people to make mistakes and to thrive and to make the decisions and to learn from them the decisions. And you would never have seen the federal government. I mean, one of the things that struck me about some of the whatever level of government, but the kind of conversation around I won't get into the details, but the Education Act, and where suddenly that broke down because there were a number of chiefs had some questions and concerns about it. Well, you would never see a government go to the Federation of Municipalities and say, get your act together. And yet First Nations have constitutional authority. and deserve the same kind of conversation, at least that you would have with mayors of municipalities, for example. So how can we have that different kind of a conversation that actually allow people to thrive and to succeed? I guess I think I will leave it there. I've talked long enough because I really want to get into the dialogue and the questions, and I'm sure there'll be other things come up later. So thank you for your patience, and Carrie.
Miigwech, thank you, David. So I want to thank everybody for having me here today, and thank you for having me in Treaty 6 territory. I want to acknowledge the territory, and Miigwech for having me here. Thanks very much to the organizers, Fleur and Michael, and the Saskatchewan Public Health Association. I appreciate you having me here today. I think David had his hand in getting me here today too, so thanks to David for recommending me. It's always good to see David and to spend time. I think he's, when you grow up and you have certain people that you idolize and that you think, oh, it'd be great if I met him one day. Well, about a year ago, I ended up being on a panel and David's name was on there, and I was like, I'm on a panel with my idols, David and Dr. Jeff Redding. I was pretty nervous, and they're really great people and made me feel very welcome. And so now I get to be on another panel with David, so I'm really excited and honored to be here. I just want to start out by framing what I have to say by two things. First is I want to talk about context of Indigenous health in terms of the area and in terms of public health and thinking about public health. And I want to talk about research as reconciliation, because I think research in our communities isn't always seen as a good thing, and there's a reason for that. And I also want to talk about why I think it is a form of reconciliation. And I may not do that all in this introduction, but as we go forward today and sort of having our discussion. And I really hope that we have some good dialogue and discussion today. So I want to first talk a little bit, and David really laid out a lot of the themes that will enhance, I think, what I have to say. But most of you probably know this, but I think it's worth saying again. And one teaching I have from my Cookum, my grandmother, is that we all have bundles, and if you don't have a bundle, maybe you call it a toolkit or a purse or whatever it is you want to call it. But when you're at a talk like this, I always say that whatever it is, if you've already heard this, then you don't need to put it in your bundle. But if you haven't heard it, then you can pick it up, put it in your bundle. So if you seem to have heard something I've said, well, then just leave it aside, and what you need for your bundle, pick it up and put it in your bundle or your toolkit, whatever it is you want to call it. And that's what I've learned. So bear with me if you've heard some of this, and hopefully you'll be able to take at least one thing for your bundle today. So I want to just start by talking a little bit about the Indian residential school system and the intergenerational effects that I think sometimes overshadow other forms of ongoing oppression. We have a lot of child apprehension, we have land dispossession, and I think we have to think about all of these things combined together that impact and continue to impact First Nations people. And so when we think about the Truth and Reconciliation Commission, I think we have to think about various forms of reconciliation and the many things that the TRC recommended. The IRS system has many intergenerational effects, including mental health issues, which many people still, there's stigma attached to that, right? Continued stigma. People don't like to talk about that, but we have a lot of trauma, intergenerational trauma. And we have depression, and we have suicidal ideation as well. That's really important to just acknowledge and understand. In 2014, the United Nations Human Rights Council found that the health of First Nations, Inuit, and Métis people in Canada is a matter of significant concern, and that even though the overall health situation of Indigenous people has improved in recent years, the significant gaps remain. And not only are they remaining, but in some cases they're widening. And that we really need to understand that. And if you look at the health when we have new immigrants coming to Canada, within 2 generations, their health gaps close, which is great. That's fabulous. But if you think about it, for Indigenous people, not only are our health gaps not decreasing, they're widening in many respects. And I think that we have to think about that, and we have to figure out how are we going to address this. This is a significant public health concern. And so we have to think about why is that happening? Why is it that we can't decrease that health gap for Indigenous people? And I think there's one thing that we haven't really truly considered, and that's the ongoing effects of colonization, and that's because colonization is not over. Colonization continues. It continues here for Indigenous Canadians. So if you look at life expectancy, infant mortality, suicide, injuries, communicable diseases, chronic diseases, all of them are higher rates for Indigenous people. So the health situation is exacerbated by overcrowding housing, high population rates, high poverty rates, and the geographic remoteness of many communities, and particularly Inuit communities in the north. There are also issues of whether equitable healthcare is available for high needs of many Indigenous communities, and we can see this, for example, at Attawapiskat and Cross Lake, as well as issues of inequality of funding for healthcare services in Indigenous communities, which was shown in the 2016 Canada Human Rights Tribunal decision regarding the 38% shortfall in funding for on-reserve child welfare system. So there are also issues about whether Indigenous people receive equal treatment in the healthcare system, and this is why I really do most of my work around cultural safety, because we know that many Indigenous people do not feel safe accessing the healthcare system, that there's a lot of racism and stereotyping, and I want to make it clear that these are systemic issues. And they're systemic issues because our whole system is built on a colonial model. So if it's built on a colonial model, then you're really looking at good people working in a colonial model, and that's very difficult to address. So I think it's safe to say we've got many people here wanting to understand how do we address public health issues, and it's because you're here, you want to do something, you're all good people. I'm not going to sit here and say, oh, you're all racist. You're not. You're working in a racist, sexist system that is built on white privilege because it's a colonial model, right? It does not work for Indigenous people. It doesn't work for a lot of people, quite frankly, but it certainly doesn't work for Indigenous people. And we have a lot of data to support that. The Health Council of Canada report in 2010 found that people found the system to be alienating and intimidating, and it places value from their perspective, from our perspective, on Western educational credentials and a lack of respect for traditional Aboriginal approaches to healing. And there are power differentials, and that's what cultural safety focuses on. It makes people really look at power differentials and systemic issues. So there are also deficits in research for key groups in Aboriginal communities. There's a deficit in research around around elderly people in the Aboriginal population. We don't really know a lot about those who are aging, for example, and what their needs are. We don't know a lot about the loss of traditional approaches to healing, for example, and truly looking at holistic healing in a significant way, not in sort of a really surface way. The Canadian healthcare system, I think, really struggles to implement cultural safety models. If you ever ask people what cultural safety is, can they truly understand it? Can they define it? Can they tell you what it is? Is it having an elder come in once a month? Is that really cultural safety? Or are we looking at something much deeper than that? Right? Because I think cultural safety is truly addressing those deep systemic issues, right? And starting with an elder might be a good idea, but can we do better than that for Indigenous people? And I think we need to do better than that, right, if we want to close those gaps. So I think some of the other things I want to touch on are really the Health Council of Canada says that we have to look at the history of colonization, at institutional discrimination, power imbalances, and really in the change in public policy in terms of training and looking at training for healthcare practitioners across Canada. The TRC also made several specific recommendations, and so when we get to looking at reconciliation, they called upon the federal, provincial, and territorial and Aboriginal governments to acknowledge that the current state of Aboriginal health in Canada is a direct result of previous Canadian government policies, including residential schools, and to recognize and implement the healthcare rights of Aboriginal people as identified in international constitutional law and under the treaties. They also called upon the federal government, in consultation with Aboriginal peoples, to establish measurable goals to identify and close the gaps in health outcomes with Aboriginal and non-Aboriginal communities. And how do we do that? We do that through research. We do that with and by and for Indigenous communities. Indigenous communities are really starting to engage in research, but the research needs to be respectful, it needs to be reciprocal, and it needs to be beneficial to their communities, because only they understand what the issues are and how the research needs to be carried out. And so it has to be done with Indigenous research methodologies, and it needs to be done in a way that builds capacity. And David spoke to this. So when David was saying he's talking about that a lack of capacity and a lack of social support and a sense of control, that all can be done when you're carrying out research in the right way. Because research can lead directly to program development, it can lead directly to training, it can lead directly to changing the policy within a public health sphere. And you know, the other thing I was thinking about as David was speaking was we have also lost our identities through this process of colonization. And as you're talking about the social determinants of health, and I always like to include colonization in that, the colonization also stole our identities, and we're just in the process of reclaiming those. And so when you think about that, you think about losing your sense of self-esteem. So we have to also think about those things as well, in addition to trauma. But let's not forget about the resilience that we have as Indigenous people, and that we can build on that resilience and use strengths-based approaches to whatever we're doing, whether we're building partnerships with our allies, with FNIB, with Saskatchewan Public Health Association, with University of Saskatchewan, because we cannot work in silos. We have to have allies. And so I sort of want to leave it there and have some discussion about solutions. How do we close those gaps? How can we use strengths-based approaches? What is the role of research? How do we start to move forward from there? And I know there were a lot of questions that I may or may not have started to answer, or maybe I just made things worse, I don't know. But I think I'll just leave it there, and maybe we can sort of move forward with the questions. And I just want to say miigwech and thank you.
Well, thanks very much for the opening remarks. I think that this look at the history of the field and some of its strengths and blind spots, potentially, as well as the inevitable shortcomings of systems based on colonization, have been an excellent introduction to the discussions that we'll have. So as you had mentioned, Carrie, in 2015, the Truth and Reconciliation Commission of Canada had made 94 recommendations, calls to action. 6 of these referred directly to the health system, and others should affect health in terms of justice or education and other areas. So I'm interested in both of your thoughts in what public health as a field can be doing, and recognizing that intersectoral nature of our work, what we can be doing to drive action in other sectors, whether that's education, social services, justice, or others.
I'm going to let David go first because I just finished talking a whole bunch.
Catch your breath. I think there's a number of things. I mean, one of the pleasing things for me about the TRC report is how differently it's been received than the Royal Commission report that identified many of the similar kinds of challenges. 30 years ago? And but there's a different atmosphere this time, a different kind of conversation. Part of it is just a recognition of just the depth of the challenges and the reality of it, and it can't simply be dismissed, because it is people within this country that were the first citizens of this country, and just sort of reading how media are responding, how professional organizations, how universities are talking. They're actually talking differently about doing something this time, as opposed to, somebody should do something. They're actually looking at changing their requirements for education or changing their requirements for continuing education. So those are the kinds of things that public health can, in engaging with various partners, change the conversation from doing to doing with or working with. And it is that journey. I mean, one of the things I've always been struck, whether in clinical medicine or in public health, is that at the end of the day, I don't have to live with it. I mean, we have to be thinking of everything as communities, and a series of communities, some of which we are participants, some of which we live in, some of which we work with. But it is these communities that, at the end of the day, have the right to make the decision. And our job is to help them make the best decisions possible. But other than, communicable disease control and you can't kill this other person, basically most of what we do really is in helping to build capacity and understanding that will allow individuals and communities to work with and aspire to who they could be. And then we can journey with them in that. And that sometimes means accepting they don't agree. And that's okay too. But at least you've been able to have the conversation and the tools. And it is part of that a different way of professionals working with communities and individuals. And one of the nice things I've seen over the last decade is some of the breaking down of some of the silos interprofessionally, some of the breaking down of silos between sectors, some of the willingness to have a very different conversation about, like when I was taught medicine in the 70s, we talked about compliance as how do you get that bad patient to do what you tell them? And that was literally how it was portrayed. Right? If only we can figure out a better way to yell at them, they'll figure it out and then everything will be fine. I mean, they didn't say yell at them, but it was in effect the same thing in terms of if people actually understand why they're taking the antibiotic and why they have to take it all, they're much more likely to do it. And if they have a side effect and you say, if anything happens or you have any questions, or call me and you actually answer the phone or somebody answers the phone, then if they have a rash or something, they're less likely to simply stop and then they're afraid of you, so they're never going to tell you that they only took 2 days worth. And then they're sicker or whatever it is. And so it's a very different kind of conversation. And I think one of public health coming out of being a bridge between the clinical and the social, between institutions and community, that this is something that public health, I think, has a big responsibility in helping to form bridges, helping to, going back many decades now, I used to describe it as part of my job as a local medical officer was help the different sectors to listen to each other, as opposed to if you only were more like me, everything be fine. I don't know about you, but how many times has somebody harangued you to get you to change your mind that you've held for 30 years or 20 years or 10 years, and you say, oh my God, where have you been all my life? Thank you for yelling at me, and I'm going to change right now. No, we go to our happy place. Politicians do that. Deputy ministers do that. It is about how can we have the right kind of conversation that we can build on a consensus of what makes sense and how to get there.
Yeah, I think that David makes some really good points. I'm going to use an example because I think I do better when I use examples. We did a project several years ago, and it's an ongoing project. It's a end-of-life palliative care project with Indigenous communities, and we worked with elders, and it was guided by a research advisory committee with community members, with people from the Regina Capel Health region, and by a male and female elder. And we had actually started the project because we had several nurses and clinicians come to us and start asking us questions, like how come there's 50 people in the waiting room all the time? We can't accommodate this, and why do people want to burn sweetgrass? Questions really around cultural safety at end-of-life care. And so we embarked on the project, and we gathered elders together, went and interviewed them, mostly out at powwows actually. And powwows are actually they're sacred ceremonies, they're spiritual ceremonies, which I don't think many people understand that until they get to understand what they're about. And from our experience anyways, and working around this. And when they do, it's an amazing when the light bulb goes on around what powwows actually are. And so we went out and we interviewed elders, and we only asked the elders one question. I mean, there were several questions, great questions that came from the nurses we worked with and other clinicians. But we only had to ask the elders one question to have all those questions answered. And the question that we asked the elders were, what would you like to say to clinicians about the needs of Indigenous people at end-of-life care? What do families need at end-of-life care? And we got all of our questions answered. And we did a 21-minute video aimed at healthcare providers that has been immensely popular. It's hosted on the Virtual Hospice website. And we did a PowerPoint video to go with it. But the point of what I want to say about this is what the elders continued to say over and over in this video was, talk to us, tell us what we need to do to open up the lines of communication. Tell us what we can do so that we can have a good conversation, so that we can have a good connection. Because what has been happening for too long is that we don't talk to each other. We're not talking to each other. We're not communicating. And when we don't communicate, that's when things go wrong. And one of the elders, she was almost pleading. She was like, tell us what we have to do. Tell us what we have to say so that we can have those conversations. Because what was happening is, and the nurses told us this, is they didn't want to offend First Nations people, so they would rather just not ask them questions. They would rather just not talk about things. And so I think David touched on something really important, that we have to start having some of these tough conversations, these difficult conversations. And maybe we're not going to be on the same page at the start of it, but we have to start having dialogue. Because these public health issues, maybe some of our issues are a little bit different in our communities. Maybe they're a little bit more acute. But I had an elder once say to me, diabetes is diabetes, right? It's not a different form of diabetes that Indigenous people have. Diabetes is diabetes. But the problem is that it's more acute in our communities. Why? We got to figure that out. And so the solutions for Indigenous people may look different. And we have to be prepared to have those conversations. Right? So I think, to me, that's where we have to have that give and take with our allies. And that's what I like to say, with our allies. Because we all, at the end of the day, want the same things. If you think about, what do we want? I mean, one of the elders on our project, he wanted to make sure in our PowerPoint that there was the natural laws were up there, because he said everyone can relate to natural laws. Love, respect, honesty. Can anybody in here say that you can't relate to those things? Because we're human beings first, right? So I think that there's something to be said about that. If we can remember what we have in common as human beings first, then, those differences, they'll come in after, but let's not start from a place of difference. Let's start from a place of commonality, and that humanity we have, those understandings we have, we can start there. And because there are going to be tough conversations, because we do have different needs, and we do have things that we do have to do differently. Because unfortunately, the reason that I talk a lot about cultural safety is we do have different things that we need. We do have different programs that we need to address our issues. That is the truth. But we all are human. Diabetes is diabetes. Cancer is cancer. And it is killing our people at higher rates. So.
Just to, I can't agree more. And it's actually very practical. But I just wanted to say something positive, and to give Saskatchewan some kudos. Saskatchewan's often led on the social policy, in the social policy sphere. I've never quite exactly figured that out, but I think partly it's having a matter of to survive on the prairies for a long time, people actually had to get along and think about the well-being of the community, not just themselves. But two things in the 90s that when I was here that I thought Saskatchewan did for health the two best things actually was one was to provide pharmacy and dental to low-income families, so you could come off welfare and not lose the pharmacy plan and the dental plan for your kids. And when you think of it from an economic standpoint, it doesn't make any economic sense to go out to work, to not make much more money, and to lose the security of these things for your kids. So by removing that barrier, suddenly there are thousands of families with people working. And you just think of the impact of that in terms of self-esteem, being part of community, feeling... Because quite honestly, it's very rarely I've met somebody that did not want to work, that would prefer to sit at home. But they need the opportunity to do that and something meaningful to do. The other was a group recognized that if you were on social assistance, you could have a phone. But then somebody would call Hong Kong, couldn't pay the long distance bill, you lose the phone. But you can get a long distance cap, so incoming calls and local calls going out unless you pay up front. And but there was a $200 deposit. Well, you don't have the $200, so you can't have a phone. So anyways, a very enterprising group and negotiated with SaskTel and to waive the deposit for a long distance cap. And suddenly I think there were 3,000 or 4,000 households in Saskatchewan that now had phones. And any of you that are environmental health officers or public health nurses or social workers trying to track people down, having a phone is important, but you also think of social isolation. You think of connection. Again, that sense of being part of a broader community rather than having to borrow your neighbor's phone all the time. Those kinds of things are very important. What we found was with the dental benefits, et cetera, is that people were happier, they're healthier. They, to the extent you can judge such a thing, they seem to use the system better. And at the end of the day, all these things are positive, doesn't cost much money. Well, what is it now? 15 years, 20 years later, what other jurisdictions have done that? Ontario does it for the first 6 months and then you lose it again. Alberta does it. But as far as I know, no other jurisdiction in Canada offers that benefit to low-income families. It's perfectly logical. It's good public policy. It's something public health should be advocating for. As just a couple of practical examples. The other thing was Alberta wanted to do the phone thing, and so they came there, and the minister at the time and I were, anyways, they wanted me to get very public about it because basically CRTC at the time, this is in the 90s, late 90s, was telling Alberta that if they pursue it, they'd kill it in Saskatchewan. Now they've changed their policy, but does anybody know they've changed their policy, that that's now allowed? No. So again, these are the kinds of conversations that we can foster that are practical. They're not directly public health, but they certainly make a huge difference to the health of the population.
Following up on those examples and case for interdisciplinary thinking and for cultural safety in public health practice, being here at a university with many health sciences colleges and a school of public health, and with both of you two as teachers and mentors of a lot of renown, what do you think is necessary to prepare the future workforce and future researchers in public health and related fields for some of these needs, which maybe have been there all along, but which we're increasingly recognizing as needs for effective practice?
I guess I'll start again. Well, there's a number of things. I mean, obviously key to it is thinking critically, thinking broadly, being open to different perspectives that we can actually learn from anyone. I often say there isn't a field of expertise we do not need, and it isn't about, I mean, I go back a ways, and I remember the days when I would say we were so busy shooting at each other, no one else had to, because the battles from health education. Who remembers the battles around moving from health education to health promotion, and then the battle between health promotion and population health, as if somehow one had to be dominant over another. They're all essential to our understanding and thinking. We should be colleagues. It's not simply an academic debate. It is about bringing the best knowledge, the best from whatever field, from whatever discipline. And is there any discipline that's any more important in public health than another? No. No, we need them all. And we need all the perspectives, and we need everybody to be being part of this, and the community as well. I mean, some of the most powerful influencers are those who happen to be there at the time, whether it's a teacher or a nurse or whoever it is, that can, with a little bit of knowledge, can actually make a fundamental difference. So opening our sense of inclusiveness and to reach out and to actually have an understanding of how we can work with diverse communities. I mean, again, going back, I'm sorry, I keep going back, and we've all learned many things, but I remember one of the very first health promotion they were doing in Ontario, and they asked me, because in those days I was doing a lot of sort of focus on clinical preventive medicine, because that was my original field, and in my area of research and stuff. And I listened to previous speakers talking about how do we get those people to do the right things for those people. I didn't talk about clinical preventive medicine. I talked about that understanding we were talking about earlier, about a sense of community. Parliament is a community, and you have to treat it and understand it as such, and what are the dynamics of that community that would allow people to actually influence that. And it's not about talking to a minister, maybe their staff, maybe their friends, whoever, but it is about understanding that each of these communities have a right, and it's not like we know better for people. Right? I mean, often we don't, and there's a long litany of stories, not just in international development, but here in Canada, where we've made a real mess of things. And because we have not listened to the community or recognized what was needed. And I mean, the classic, a young woman who I watched grow up, but she ended up going off with CUSO, and I remember this letter she wrote back that I ended up seeing, but she was talking about how they recognized there were piles of garbage in the community, in the village, and so they thought, well, wouldn't it be cool if we raised some money and we can get garbage cans? Well, there still were piles of garbage, and finally they had this brilliant idea, why don't we ask the community what they need? And the community said, well, we actually need a better schoolroom, and that's what they worked on. And there's just countless stories of that. And engaging the community in those decisions, funny thing, it actually works better.
Yeah, I agree. I think we have to start to think outside the box. The programming that we do at First Nations University, we try to engage community as much as we can. Many of the new courses we have, well, one course we have that we've been teaching for 15 years is actually taught only by an elder. Strictly by an elder. It's a holistic health course, and we still have to, fight pretty diligently to have that course taught by an elder. Academia, I think, sometimes moves in the wrong direction where they want credentials, and so we still have to fight fairly hard for that. But we continue that fight because I think it's really important to recognize that there's more credentials than academic credentials. In our communities, elders are our PhDs. That's who we go to. So we've been really continuing to fight hard for that because it is a different way of learning to learn from an elder than from a professor or an instructor. We're also developing some courses that will be ready soon where they're community-based courses, and students will actually learn in the community and to the benefit of community. So I think that is really important when you talk about what do community want. Well, community has also a lot of knowledge to offer, and so what better way for a student to learn than to not just do a community placement. I mean, to truly go and learn in community. So that's what we're working on. Our Bachelor of Health Studies program actually also requires a work placement, and often they choose to work in community agencies, because that's where a lot of them want to do their work if they don't go on to do a master's or go on to medicine, and many of them do as well. They don't start out that way. They start out saying, well, I'll be lucky if I finish my Bachelor of Health Studies, but many of them gain that confidence through the process where they realize, hey, I can go on to medical school. I can go and do my MPH. I also think there's something to this that I really want to work on is land-based courses, because if we're going to talk about research is reconciliation, and we're going to talk about holistic health, then we have to be out on the land to do that. So I know U of S is breaking the trail here in that, but I think it's really something to it to do land-based courses. And we do have some where we go just out for a week and kind of do the week thing, but I'd like to do something where it's more ongoing and truly out on the land with the elders and the knowledge keepers, learning that way. So I think there's room for that in academia. And I think there's room for that when you think about, for example, many of the Royal College. I sit on the Royal College of Physicians and Surgeons of Canada, and they're finally starting to look at making it a requirement for all physicians to be accredited in Indigenous health, and that's a huge breakthrough. And so I think that it'd be great if we were able to start moving that into something that's professionals are able to engage, but not just something academic, something that's truly meaningful, that is knowledge, knowledge and land-based. So we're working on that, and it's been a long time coming, and it'll be great to have that from, all the way through to adult learning. So I agree. I think that there's room for this and all the way through, and that community-driven piece has to continue to be there all the way through, whether we're talking about academia, whether we're talking about allied partnerships.
So noting the time, I think all of us who are involved, including the panelists, really are excited for this to be an event that's responsive to the audience that we have, both in the room and online. And I'm interested to know if there's any questions at all that you would like to direct this way.
Or statements.
Yeah.
My name is Dr. Morales. I have a PhD in Edmonton.
Could you please just press the button that's there?
My name is Dr. Morales. I am a general surgeon. I graduated from this university and also studied in Paris. And I have a PhD from the University of Alberta. And then I am from El Salvador. And we have a Truth and Reconciliation Commission at the end of the Civil War in 1992. I follow also the Truth and Reconciliation Commission from South Africa. There is a Truth and Reconciliation Commission in Nepal, at the Civil War in Nepal. But one of the mistakes that we made, and I hope you won't make that mistake in Canada, is that we didn't establish what we in Harvard call the QQTRs, which is to establish the quality, quantity, time, and resources you want to achieve things in a time frame. Because in Truth and Reconciliation Commission never established that, and they leave whatever happens is going to happen. And I think in Canada, even the Truth and Reconciliation Commission for the Native community is not doing that. It's just a framework, but there's no established the QQTRs to achieve things on a time frame with resources.
I agree with you, actually. Yeah.
No, it's a very important point.
Yeah. Thank you.
And that's one of the challenges with royal commissions and things in the past, where it just there wasn't an implementation plan, which is kind of what you're alluding to. And I think that's where not just public health, but our colleagues in other sectors, different levels of government, there's a different kind of conversation. I mean, among deputies and ministers now that I've not seen, and within professions. I mean, when we were talking about this with the Royal College, 2 years ago, could never have imagined them even considering it. And if it goes forward, it is in fact the first time they have ever said for all specialties this would be mandatory. So anything, this would be the first time. So just the fact that they're willing to consider that, I think there's a, I think I'm always an optimist, but I actually think I have reason for my optimism now. Other questions or comments?
Okay.
This is from Mr. Khan, M. Khan. It's for David particularly. In spite of importance of determinants of health, why they have not been part of the public? Why have they not been part of the public policies? Is it because of a lack of leadership in public health, or indifferent attitude of politicians and governments?
That's actually a very good question, which you can probably tell I've struggled with for a long time, and there is no simple answer. I mean, it is. It's always this dynamic of of interests and desire for common good, but then self-interest and the reality of the political process that as much as we might hope the political process will lead, it's rarely in their interest from a voting standpoint. But on the other hand, if there are compelling reasons and collective, I'll give you a very practical example. For the longest time in public health, we were talking about what public health meant, the value of prevention. I remember when I chaired the Coalition for Enhancing Prevention in Professional Practice, which was the 13 different national professional groups, and we built a consensus around prevention and a statement around the value of prevention, not as a be-all and end-all, but in terms of balance of the system. And my colleagues at the CMA refused to endorse it. It was the only professional group that did not. But then to see a decade later them arguing with their colleagues in other professions, the Minister of Health, that we really need to focus more upstream and more on the social determinants and more on. So there is there's always hope. And I co-chaired the review of public health capacity in the early 2000s, and when it went back to the Conference of Deputy Ministers that had commissioned it, the head of the Advisory Committee on Population Health presented it, and there wasn't a single deputy that was there that commissioned it, and they basically put it on a shelf. And then 2 years later came SARS, and they pulled out the work we'd done in the 90s. They pulled out that report, and they said, you knew, because we said we're coping just barely, but don't give us anything too big, don't give us too long, and don't give us two things at a time. And that's just on the emergency side, let alone all the chronic disease and social and other stuff. And but at that time, we also had started the Coalition for Public Health in the 21st Century that I chaired. I know I seem to be awfully in the middle of stuff, but anyways, by accident purely. But we'd come up with, this was professional associations as well as NGOs and others, came up with 6 things that needed to happen to move public health forward, at least federally. And what was really surprising at the Naylor Commission was to see submissions from pilots associations, from all over the place, basically endorsing the same 6 things. So if you're focused and if you can bring a collective positive answer, as opposed to, you have a problem that you need to fix, but here's some solutions that can do it, and we can help you with doing that, it's amazing how you can move some of these debates further. And you never know when the stars will align, so you have to be ready for it. You can't just wait for them to align.
Yes, please.
Yes, I'm delighted to hear that the universities are looking at implementing a process whereby healthcare professionals will be all required to be knowledgeable about Indigenous health, but I wonder how they propose to ensure that the physicians and the healthcare providers in the community today are brought up to snuff with regard to that issue. That's just, and I have a second question. I'd like Dr. Bourassa to talk to OCAP as well while we're on this subject.
Sure, I'll start with the first one, and Carrie can pick it up further. It was actually that we're talking about the college, like the professional colleges, not universities. Though many universities have made a commitment to make it core to the education across all faculties. But the intent would be, if this comes through, is that not only would new specialists have to, as part of their licensing exam, their specialty exams, to be competent in these areas, and so it becomes part of their training, which then medical schools want to do, but also that there would be core curricula that is part of, because we're all required to do continuing education, that over the space of 3 or 5 years, whatever, a number of modules that would have to be completed to bring the field along. And I know there's discussions in other professional organizations as well. I'm just not as familiar with where they're at in that, but that is something that nursing can push their organizations, and each of the professions can sort of raise that with their own organizations.
So I know the Canadian Medical Association is seriously considering it for sure, and we have invited the Canadian Nursing Association. So I don't know where they're at, but you know, we're trying to sort of get as many licensing organizations involved as possible so we can kind of get everybody on the same page. But you can't guarantee it, of course, right? But you know, if you get one large organization, influential organization like the Royal College to do it, other people are going to want to follow suit, basically, right?
College family physicians also.
Oh yeah, and College of Family Physicians, yeah. So we're hitting the big gun, basically, and we're hoping that will, right? So OCAP, the ownership, control, access, and possession. OCAP is really important, and here's why it's important. I sat on CHR's ethics committee for 6 years, and we did some really good work in producing a document that had what I felt was a little more teeth than what the current Tri-Council policy has. The TCPS2, as they call it, and now they'll have a third one out, I think actually might be released already. It's fine, but it doesn't really have a lot of, well, it doesn't have teeth. It doesn't have any real teeth. It doesn't sort of say you should go out and sign a research agreement with Indigenous peoples. Chapter 9 is the chapter on working with Indigenous peoples, and it doesn't sort of say you should get a research agreement, you know, before you work with Indigenous communities. It says, well, you should think about it. It's a good thing to think about, right? And I'm being, you know, kind of tongue-in-cheek here, but really that's really what it says. It says here's some things you should think about, but it doesn't say you need to do it, right? Where when you think about if you're applying to CIHR says you need a research agreement to be submitted within a year of your project getting funded. So it's kind of contradictory, and the guidelines that we developed at CIHR, well, we were told they were redundant now and would confuse people, and so those got shelved and archived. You can't. There's no more guidelines for CIHR yet. If you're a researcher and you get a grant from CIHR, you must submit that research agreement if you're working with an Indigenous community. And so it's kind of difficult for researchers to figure out, right? It's confusing because you look up in Chapter 9 and it doesn't say to you, hey, you need a research agreement and you need to look at data sharing. And it just kind of says, well, it kind of reminds me of, you know, Captain Jack Sparrow. They're more like guidelines. Really, right? It doesn't really say to you, oh, you didn't get my reference. Nobody watches Captain Jack? Come on. You know, it's kind of like that, though. They're more like guidelines. It doesn't really tell you you ought to do this because it is fundamentally important to do this. What I like about OCAP was a political response to the fact that primarily the federal government was collecting data and not sharing it with First Nations people, and it was using it for a purpose that was not consulted with Indigenous people, particularly First Nations on reserve, and it was being used sometimes in a way that would stigmatize First Nations people. And so really OCAP was initiated by First Nations people. It was a political response, and it's about self-determination. That's really what it is. And so it's important for you to be very familiar with OCAP. You can Google it. There's all kinds of information. And I use OCAP, and I'm one of those researchers that some people say that you can only use OCAP if you're working with First Nations on reserve, and I don't feel that's true. And I work with First Nations on reserve, I work with First Nations off reserve, I work with Métis people, I work with community organizations like All Nations Hope Network that work with First Nations, non-status, status, Métis, Inuit, doesn't matter. And I use them as guidelines because you can make them work for you by communicating with the community that you're working with. And they work because you have to sit down and have a conversation well before you ever start any kind of research, and you talk about what that research is going to look like, how it's going to benefit the community, how it's going to benefit you. That means you have to have a really honest, discussion and think about that before you go in, because it's going to benefit you as a researcher. But that reciprocity, right? There's certain concepts I think you have to think about as a researcher. And when you're doing Indigenous community-based research, you have to think about things like reciprocity and thinking about relationship building and the collective. And you have to think about giving back, and you have to think about cultural responsiveness, respect, those concepts before you go into this community-based relationship. And I always say to people, community-based research is not for everybody. It takes a long time. It's a commitment. And if you're prepared for that commitment, that's great. But you also have to realize that First Nations communities or Métis communities or whoever you're working with, they're in the driver's seat. They're calling the shots. And so when you're thinking about that and you're working through your research agreement, realize it's going to take a long time. And if you're just starting to work with that community, then it might take a year to build your relationship. It might take a month. It could take 18 months. I can't tell you, but be prepared to take time to build that relationship. And you might find some communities are very research savvy. I have one community, they have multiple research projects, they know what they want, they understand, they'll have a template for the research agreement, they'll be boom, I know what I want. Some communities are not. And you have to work through that process with them and understand maybe that they don't want to hold the data because they don't have the capacity to, right? And you have to work through processes with them. So ownership is not necessarily about you not having access to data. It's about working through and negotiating what that means, right? Same with control and access. Who's going to have access to it? For what purpose are you going to use it? How are you going to publish that data? And communities want to make sure that they're not going to be stigmatized. They want to make sure it's used for the right purposes, that they're going to have full access to that data, that's going to be used to their benefit. All these kinds of things. And so it's just about negotiating all of these things out and having really clear, honest discussions, and sometimes hard discussions, right? Because they're fully aware that it's publish or perish for academics too. But maybe you're going to have 15 people on a publication, right? So it just be aware and do some research about OCAP if you're not familiar with it. There's lots of really good articles out there. And make sure you go in prepared. There's templates on research agreements, on data share agreements. You don't have to reinvent the wheel. And you can still use those Tri-Council guidelines if you like. I use both sets because when you're applying for grants, CIHR likes to see both. But have those conversations with community.
Just to add to that, just quite honestly, I think any good research requires the application of those principles. If you're going to work with communities or even individuals, if you're working with test tubes, it's a different story. They don't negotiate very well. But it is. I think it's fundamentally good research because, quite honestly, I've seen so often smart researchers go into a situation or community, come away with these brilliant conclusions that are absolutely wrong, because they didn't ask the people what it meant. And they were totally off base because what they bring is, we bring our own biases. Even in the nature of the question we ask. And so negotiating early, what are the right questions to ask, I think is absolutely critical. And I'll just give totally non-directly related story, but I remember my dad used to work for, he was directed the Labour Safety Council in Ontario. But I remember in his early days when he was investigating a worker in Thunder Bay who had blown off one of the grain elevators, and the guys there said, "Well, everybody knows you never open that door in a high wind," but nobody told him. And if you just did your measurements and looked at that and said, "Oh, we need railings, we need this, we need that," no, you need a lot more. And it's only in asking the community that you can get that understanding. If they develop with you, you will actually get really good data, particularly if they know it will help them to understand their communities and what they can do further with it. The best data comes from those who will benefit from the data. And whether it's in surveillance, and I tell, trying to do surveillance systems, if you're not giving feedback to the people that are collecting the data, if they don't find it useful for their patients or clients or whatever it is, you're not going to get good data. But if you do, you will get the very best data. And that's the only way to go.
Yes?
I'm speaking of biases and stuff like that. I'm just wondering what your perspectives are on culture and the protective properties, I guess, in implementing in public health, and I guess within the public health sphere that you guys find yourself, I guess, because it was mentioned in the TRC calls to action, I guess, you know, the marriage between Indigenous practices or you know, interventions, you know, kind of marrying the two of Western Indigenous interventions. And there's been a lot more of talk between the protective properties of culture as far as a prevention tool as well. Just wondering what your thoughts and perspectives are coming from your respective fields.
Sure. Yeah, I think that's it's definitely I think it's definitely needed, and I think learning from the elders and knowledge keepers, there are some things that can be shared and should be shared, and there's traditional knowledge that can be shared, that sort of holistic health, those holistic health concepts, and then there's sacred knowledge, and so I think there's sacred knowledge that can't be shared, and those things we know can't sort of be integrated sort of into mainstream health. But there is a lot of cultural knowledge that can be shared, and that can be helpful. And I think what I've learned is that it's our time to start sharing our knowledge, right? That can be beneficial not only to Indigenous people, but for anybody, right? And I think that now is that time. And so I think that the recommendations that the TRC made were thoughtful and alluding to that we have a lot to share that we haven't been able to share because of the residential school system, because there was a lot of fear, and we had to hide our culture and hide our traditions, and you know, they sort of went underground, right? And now I think we're coming into that time where we can share those things, and we have to sort of meld. It's that two-eyed seeing model. I don't know if people are familiar with that, right? That we have a healthcare system that right now is primarily clinical based, and there's a time now where I think it's coming, we can start to shift that and integrate a more holistic model where we can have some of our interventions that we know can help to heal, right? And I think especially when you think about, we talked about trauma earlier, and I don't mean to be the person bringing the sad story, because I think we're very resilient, but we're resilient for a reason. We, as much as we might hold trauma in our, you know, intergenerationally, we also hold our culture intergenerationally, even whether we know it or not. And now it's a time for us to bring that forward. And so if we can blend those two things, blend sort of the Western viewpoint with our Indigenous perspective and knowledge and culture, then I think that we have something that is really powerful. And a lot of the elders that we've talked to and interviewed for different projects, they say that a lot, that we can't really work in silos. We have to bring those two things together. And so I think now is the time for that. And I would really, really like to see not just having an elder come in, you know, to a doctor's office and kind of sit there, and, you know, but really integrated Indigenous medicine, Indigenous, you know, knowledges that can really benefit people, all people, you know, and I think the time is coming. I hope that helps.
Yeah, I mean, there's a complementarity to it. I mean, my ancestors, who are somewhat more recent immigrants to this continent, I mean, the arrogance of many who came and the policies that followed, and I do wonder how much knowledge has been permanently lost in terms of dealing with the land, with the environment, with natural medicines or whatever, and what is residual that we can rediscover, and it's funny how that arrogance gets in the way when you know, we're willing to look to many different cultures for knowledge to enrich our understanding, and yet in our own land we haven't taken advantage of the millennia of experience. Now maybe we can, and I think, but it will require a genuine reconciliation as part of that, and an openness to learn and also to evaluate, right? I mean, because again, we all have faith traditions, we all have cultural traditions, even the Gaels and the Celts. I mean, there were things that, quite honestly, in my own culture, that were lost as we became more, I don't know what it was, but we lost some of that basic Indigenous knowledge in Europe as well. And how do we bring some of that back as well?
Question, because I work in Canada, in North Battleford, in Prince Rupert, in North Place in British Columbia, and I work in New Brunswick, and also in St. John, Newfoundland. And then I had a view of what happened to the Native people. And I also have a view of the participation of the doctors in prevention and health promotion. I can say to you that most of the doctors in Canada, there's exceptions, don't care about health promotion, don't care about prevention. For example, family physicians just want to see you in 3 minutes, exceptions are. Or 4 minutes, give you the prescription, don't give you an exam, physical exam, don't do anything, you give you the prescription. It happens also in other levels. I am a general surgeon. We are not much concerned about how to prevent atherosclerosis. We want to fix, as you said, the fixers want to fix the aortic aneurysm. And then I am happy that this issue of training the new doctors on health promotion and indigenous issues of health might help, but if we leave it in an empty space without doing something to secure outcomes in the future, nothing is going to happen. I know that this doctor, for example, in Nova Scotia, they have a running program. It was started by a doctor. They have now 50,000 children running in a competition every year, and that's nice. But you have to have some sort of definition of where you want to go. Because you live in limbo, you never achieve anything.
That's true. It is about, again, it's not about prevention versus treatment. It is about what is the balance, and if we can look at things from the standpoint of what's the compendium that results in the best health, right? If it were any other investment, we'd look at all the pieces and say, at the end of the day, our measure of profit is health. And so what are the investments that will ultimately lead to the best health? I am struck, though, compared to 10 or 20 or 30 years ago, the number of in medicine specialists and others who are recognizing the limitations and are seeking, and even statements from the Canadian Medical Association, which are much more about getting at the social determinants, getting at prevention, etc. Even if individual clinicians can't be bothered because it's not their realm, the profession is much more open and desirous of understanding the complementarity of the different spheres than I certainly remember 10 or 20 years ago. Does it have a long way to go? Absolutely. And we have all kinds of disincentives. I mean, the way we fund a lot of services, etc., it's a disincentive to that comprehensive care and that thinking of prevention as much as you think about treatment and care. And so there's a lot of aspects to it, but that's one role that public health can play. And one of the advantages in having more integrated systems is when public health practitioners are part of the conversation for the planning of health services and what are the alternatives in terms of what health authorities are trying to accomplish, that can be actually very powerful. And that's, again, another example of the influence, not just the programs and service that we deliver. And that has to be part of the training of public health practitioners, is your role is not just to manage these services, but your role is to find ways to engage with other sectors so that the culture can shift into the kinds of ways that we need to be. And I've seen it work. But it's not universal, and not everybody takes advantage of that opportunity. So, but it is a part of our realm that we have to do more in. You're absolutely right.
I wanted to follow up on some of your opening comments, Carrie, about the impacts of residential school and other aspects of colonization on mental health, including on depression, on addictions, or suicidality. And from some of these discussions, I'm interested in what both of you think about our understanding of trauma and also our understanding of strengths and how we can apply that as a field to addressing mental health in Indigenous communities and otherwise in Canada.
Jimmy, go or you want to go?
No, go ahead.
Well, I think it's amazing how little we actually know. We have suicide data, of course, and we know suicides are the highest among Indigenous people, and actually the highest among Indigenous women age 18 to 24, about 8 times the national average. So youth are the highest risk, of course, but it's in some places youth, the suicide rates can be 10 times the national average. So it's something that some communities have a state of emergency, and in our communities, what we often see is what we call multiple loss. I do a lot of work in end of life and palliative care, and typically when you work in end of life palliative care, in the general Canadian population, you're often dealing with death due to chronic diseases, cancer, usually older adults. Our populations, it's young people. It's deaths are due to motor vehicle accidents, injuries, and suicide. And sometimes suicides happen in sort of in waves, and they'll happen multiple. What we call multiple loss. So what we deal with in our communities, it impacts not just one family. It impacts entire communities, and it'll happen in groups of communities. And so, there's huge mental health stigma around and lack of support. And what you saw when Attawapiskat and Cross Lake declared states of emergencies for their youth, when you ask the youth how things could be improved, when you actually asked the youth, it were the things that David was talking about before, right? It were things like, we need a swimming pool. They didn't want a bunch of people that they didn't know flown into their communities. Surprise, surprise. Right? They wanted people that they could trust to help them. They wanted some parenting classes for their parents. Right? Well, why? Because we're dealing with intergenerational trauma. People that don't know how to parent because they come from residential schools. And again, this isn't about blame. This is about context, right? This isn't about blame. It's about context. Understanding context. Nobody can go change the past. This is just about putting context to things. And how do we address what we know are still being carried out in terms of results today, impacts today. They wanted more things to do in their communities. They're in isolated communities. They don't want to be removed from their communities. So many people, if you're reading anything online, people are saying, well, it's easy, just move. Just move. That's their home. Right? What would you ever do if somebody said to you, oh, you don't like Saskatoon? Well, just move. Just get up, just go. Right? It doesn't matter how much you might complain about your hometown, it's still your hometown, right? So they wanted very simple things, and it all comes back to, addressing root causes of poverty, of social isolation, of geographical isolation, very, very simple social determinants of health that could be addressed. They weren't asking for the moon and the stars. So I think addressing things like stigma and looking at those social determinants of health are really, really priority. So I think, and having conversations in the community, even in our own communities, we're not very good at supporting each other because you're taught from a very young age, intergenerationally, not to talk about mental health. You don't talk about mental health issues. You don't talk about your feelings. You hide your feelings. Right, and that again is sort of that intergenerational trauma from being in residential schools. So these are issues that people just need to understand, and also know when some things have to be dealt with in communities, and ask communities, what do the communities need, instead of sort of communities don't want saviors, right? Communities generally know what they need, and asking communities, what do you need? How can we help? Not making assumptions about what they need. And again, sort of trying to fly groups of people in and ask communities, engage with communities as allies instead of making assumptions. But I think, those are the main things that come to mind about addressing some of these issues, and David might have some other ideas.
Yeah, I guess, we make so many mistakes, and it is actually quite fundamental. I keep going back to Chandler and Lalonde's work, looking at communities in BC where when communities actually have land claims settled, they have control over their education system, their police, fire, health services, the community actually has a sense of control, adolescent suicide virtually disappears and is less than the general population. And we see that everywhere, where kids that have a sense of control, a sense of future, that what they are and who they are matters. There are some who will commit suicide. There's endogenous depression in kids as much as there is in adults, but those kind of what we see in so many communities, and we forget that there are many Indigenous communities that suicide is virtually unheard of. Right, and what are those factors? What are those positive things? And it is about counselors. There's lots of, anyways, I won't go there. But the point is that having something to do, having rec facilities, having education that feels relevant, and the other thing is how communities are perceived by others and how others talk about them. I remember when I lived in that other city in Saskatchewan, a little south of here, starting with an R. When anyways, my daughter was going to U of R at the time, and our van was stolen. And at that time, in some of the gangs, it was part of the initiation to steal a minivan at one end of town, drive it to the other end of town, and trash it. And people were saying, "We got to lock them up. We got to do all this kind of stuff." I said, "Excuse me. If I were growing up in a family with that, history of trauma, school didn't seem very relevant. Everybody told me I was dirt, and my future was pretty bleak, and the only respect I got was from the gang, I'd steal cars too. Thank you very much." And they'd look at me funny, but I said, "No, that's absolutely true. Think about it yourself. If you're in that kind of situation, what would you do?" And I think those are the kinds of questions we have to ask more often, rather than judging people, saying what I would do if I were in that situation and faced with those obstacles. And suddenly people are having a different kind of conversation. I think that's part of the change in the media conversation these days as well.
Yes, please.
Hi, I'm Hilary Goff. I work for an organization called Upstream, and our mandate is around educating the public around the social determinants of health. And I've always felt uncomfortable about some elements on that list. In particular, some people include Aboriginal status or something relating to that. Dr. Bourassa, I heard you earlier mention colonization as a social determinant of health. And I wonder if you could speak a little more to your use of that term, and also if there's any work you could direct me to in terms of folks who are talking about that specifically, because all the concerns that I have around Aboriginal status as being a social determinant of health or listed in that list, they all kind of get resolved when you frame it that way. So I'm interested to learn more.
Sure. Yeah, I actually don't think Aboriginal status is a social determinant of health. I don't think me being a Métis woman makes having Aboriginal status makes me at risk for anything. It's not a good connotation, right? But I do think colonization is an important determinant of health, and I've been sort of trying to really frame it that way with the Public Health Agency of Canada for a while now. And I usually when I do a talk like this, if there's anybody from Public Health Agency of Canada, they usually come up and talk to me about it. So I think there's some headway being made there. At least I hope. There are a couple other organizations, I have to look it up and I'd have to get back to you because I can't remember off the top of my head, that are actually starting to use colonization as a determinant of health. I know Dennis Raphael he's an academic. I'm not sure, I can't remember which university, might be U of T. York, there we go. He actually does use colonization, social isolation. I think he might use identity, which I'm not keen on, but I think he also uses colonization as a determinant of health, and there's a few others. So and I agree with the social isolation aspect, geographical location. So there's a few others also that I'm working with and doing some. There's a group. I do a lot of work around HIV and AIDS, and there's a group that are using colonization. So some people are just starting to create their own lists and drafting their own lists around what they think the determinants of health are. And I've been asked by a women's group doing sexual health and HIV work with Indigenous women. It's a national group. They asked me to draft our own social determinants of health list to include colonization. So I haven't gotten on it yet, but it's on my list of things to do. So we'll be drafting our own list as well, because we're not comfortable using the Public Health Agency of Canada's list, because it doesn't include colonization. And the reason that I include colonization is, in doing the research I've been doing for the past 15 years, when you start to compare data, the factor that's missing, the factor that where I see why the gaps remain and why the gap continues to widen, is where the difference is that I see. And I know colonization has occurred in other countries, don't get me wrong, but not that colonization hasn't happened elsewhere, but colonization continues here. Canada is one of the only countries that continues to define their Indigenous people, that continues to have archaic legislation govern our communities. And in doing that, colonization continues here. Sometimes in a very overt manner, and sometimes in a subtle manner, but it continues. And not only does it continue, but we are still dealing with the after effects of colonization, and let's not forget attempted genocide. And I'm not even going to use the nice word assimilation, because it's not true. It was genocide. So we have that to deal with, and this continuing, colonization. So I think it is not something that, we just sort of are dealing with the after effects, but we're continuing to deal with it always. And so until that ends, until we stop, having a government tell us who we are, and we stop having this legislation govern our communities, we can't say that we are not a colonized nation. And every time one of our prime ministers says colonization doesn't affect us, we're not a colonized nation, we didn't have colonization here, that is a bold-faced lie.
Can we just, absolutely put to rest the notion that Indigenous status has anything to do with being a social or health determinant? Because, quite honestly, if you take those of European extraction, you put them in similar circumstances, or from any other cultural or whatever group, and you put them in similar circumstances, they have similar health outcomes. It has nothing to do with race or status.
Yeah.
Yes, please.
Hi, Carrie. I have two questions. Number one, I just want to follow up on what you mentioned earlier about the Indigenous health curriculum. And does the College of Family Physician have that included already, or is that a work in progress?
So they're just considering it now, but I'm really quite confident that it's going to follow through. And we had a symposium that we invited David to, and several other stakeholders, and I'm pretty confident it's going to go through.
Great, thanks. And
we've had follow-up meetings with the Royal College and with the CEO and president and others, and I think it's. They are absolutely sincere, and they just have to figure out what it would look like, and they have their processes to work through. So we have to respect that, but we can continue to nudge our professional bodies.
And then I guess my second question is, at the start you talk about sort of research as a tool of reconciliation, and that research to be done with, by, and for the benefit of Indigenous community. So what can non-Indigenous researchers do to contribute to that? Are there roles for non-Indigenous researchers?
Yes, I absolutely think there are roles for non-Indigenous researchers. I think, as I said before, we need allies, and we can't do this in silos. What I always tell my students, and I've got, I have 8 graduate students right now working with me as their supervisor or co-supervisor, and then several in my lab. I think I have 8 in my lab. And in my lab, all of them are Indigenous except for one, and then I'm supervising about 4 allied students and 4 Indigenous students. And what I tell people is that you have to really ground yourself and look at your lens and do some good, hard cultural safety work in looking at your biases. Right, look at your values, so that when you're going to work in the community or going to work with your partners, that you're really clear about your lens and your value system and your biases, right? Because we all have them. You know, I have biases too. And if you pretend that you don't, that's where you get into trouble, right? So and just, know your, like, when my one student said it really well when she was working through her master's work, and she was working in community, and she had to write her piece about her lens at the start of her master's, and she said that was the hardest piece she wrote out of everything, because you have to really think about yourself for a minute and think hard about what is my value system, what is my lens. She said, because as a white settler, as she called herself, I never have to think about that. Right? So you have to really think about that and continue to reflect on that, because you'll change and grow as you work with community. And so, for her, she kept a journal and just, continued to do that. But, we need allies. We can't do this on our own. And how else are we going to grow and live and work together, right? So absolutely.
Yeah, no, just ditto. It is. I mean, again, it's like, only WASP guys can research WASP guys. Like, that's just bizarre, right? But you have to go in exactly as Carrie talks about and recognize that we all have biases. Science is biased. We all bring baggage to it by just the nature of the questions we ask, how we interpret the answers. There are biases in everything, and this at the CITR conference I was talking about the false idol of randomized controlled trials. They are important, and they were devised for medical for medicines and procedures where you actually need that. But when it comes to observing communities, you'll never have a randomized controlled trial. And to dismiss all other evidence as not being as good simply because it's not an RCT is absolutely bizarre. It's like dismissing 90% of the history of science and evidence and the understanding of our world, which did not come from randomized controlled trials. And sometimes it can lead us very astray. I'll give you a very practical example, a fight I have with Cochrane. And Cochrane did reviews of seasonal flu and antivirals. And they're not much use in seasonal flu. You might save a day or so. It costs $50, whatever it is. Hopefully you don't have any side effects. But in a pandemic, it's totally different. And they made the statement that antivirals were not useful in a pandemic, based on looking at seasonal flu and RCTs. And you're not going to do an RCT in a pandemic because you will kill people, literally. And we have abundant evidence. I mean, I can give you a long list of evidence, but one very simple one is in the spring, if you were a young pregnant woman and you got influenza, you had 5 times the risk of dying of your sisters who were not pregnant. We mounted a campaign through the latter part of the spring and the summer with obstetricians, family docs, and in the public have Tamiflu on hand, and at the first sign of the flu, take it. In spite of having 10, 20, 30 times more cases of flu in the fall, we had 0 reported deaths in pregnancy. I call that evidence.
Oh, thanks. The conversation on mental health turned to the health of young people, to youth and young people. And there are a number of submitted questions that we had that related to an issue affecting future generations, climate change. So with that recognized by many national or international bodies as potentially one of the biggest public health issues of this or the next century, how can we as a field work to both mitigate, prevent future climate change and adapt to it while being sensitive to the needs of our communities locally?
This is where many years ago, as I started talking about it, I realized about all this is so big. How do you solve poverty? How do you deal with these big issues? And so I try to break it down. I use the acronym PACHM, which is Partner, Advocate, Cheerlead, Enable, Mitigate. And it is about finding partners, others of like mind that we can work with on it, whether it's strategies, local municipalities or communities know where their elders are. So if there's heat stress days, they can actually make sure that they're safe, etc., or any number of other kinds of adaptation or mitigation efforts. Advocacy, that's really being evidence to bear. And one of the things that I don't hear often enough being talked about in the climate change debate is that guess who's going to suffer the most? Well, surprise, surprise, it's going to be once more the poor and the vulnerable, because they're in the most marginal lands. And you look at what happened with the tsunami in Banda Aceh, with several 100,000 deaths, and you look at a similar tsunami in Japan. Big difference. What is that? Well, it's about Banda Aceh was under military rule, it had years of poverty and everything else, and living in low-lying areas, etc., 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 lousy housing. You're going to have a big difference. And so we really need to be thinking about that. And social migration. Guess who can move out of the area into the highlands? I can afford to do that. A whole lot of people can't. And it is totally changing life for Indigenous people, particularly in the north, whether it's the Cree or the Inuit, the Innu, and changing with climate and the impact. You look at muskox, they used to go through one parasitic cycle a year. Now they go through 3. What impact does that have on country foods? Is that a danger? Is it not? Are there ways to make it safe? Because we know country foods are incredible health benefit, plus culturally beneficial. And so we need to be engaged in those kinds of, in that kind of work and kind of conversations. Cheerleading, well, that's basically not nitpicking, not getting in the way, not saying everybody else is stupid. I won't belabor that one, but anyways, enabling, these are the things that we do, right? These are the kinds of things in terms of how we organize, how we relate, how we engage in the conversation, how we don't ignore the conversation, how we don't just get into haranguing, but we start talking about the practical issues. And whether you believe in climate change or not, these things are happening. You just look at the curves in terms of serious storms, etc. It is changing, whatever the cause. We know what the cause is, but even with skeptics, it's not like these aren't happening. And so what can we actually do about that, and how can we actually mitigate it? And then it is about doing the kinds of things examples I talked about, ways in which we can reduce the impact in vulnerable communities or in communities that live there who maybe aren't vulnerable, but their livelihoods and everything else depend on it as well. So just as one way.
Yeah, I don't have too much more to say than David. I know with some of the research we've done, I've done a little bit of research with on water and looking at the environmental impacts of climate change. And the elders will say, there's fish that are being contaminated, and the same thing, the migration patterns are changing, and when hunting is happening, there's all kinds of tumors and whatnot being found in the moose and elk, and they're attributing this to the contamination that's happening, not only through climate change, but also through other means, which I don't have time to get into all of that. But it's so that is affecting their diets. It's affecting their hunting, and which is a very important part of their traditional activities. And so they're turning to other kinds of foods, which are not great, and it's expensive in many communities when you can't hunt. So there's all kinds of impacts that are happening, and I think that there has to be, again, just some recognition of this, and there's got to be some kind of solution through a combination of research and action with the services that are available, because it is really impacting communities when you're already poor and you don't have access to the good food box, and you don't have access to a food bank, and now your hunting is compromised. It is really, really impacting some communities. And it's hard to sort of look at strength-based solutions in communities and get people sort of excited when they don't feel they have any options. So it is a huge issue, I think, and it's getting worse, unfortunately, instead of better, as we see the climate issue getting worse, and contamination getting worse because of pipelines and whatnot going through through territories. And I'm actually working on a project in Treaty 8 territory, and there's litigation and there's all kinds of lawyers' fees, and now it's affecting clean water. So yeah, I think that we have a whole lot of work ahead of us, but I do really think that there's are always solutions when we work together, and I really think that David's ideas are practical, and I think we can move forward in many ways.
Right. Well, I think that's an excellent set of thoughts to end on. I'm sure many of us would love to stay and ask another 2 hours of questions and hear more of what you have to say, but we do need to draw to a close. So I want to thank you very much and turn it over to Wanda.
Oh, it's been a pleasure.
Yeah, it's been great. Thank you.
Thank you.
Thank you very much.
Thank you.
And just the Saskatchewan Public Health Association is being launched officially with this panel discussion, and we really hope that you'll all become members. And we really thank you so much for this. This has been given the board, I'm sure, a lot to think about, and a lot of our board members are here, and so we can really work together, and it's been really helpful. So thank you.
Lovely to be on a panel with you again.